First and foremost, I want to thank Lieutenant Colonel Snow for inviting us, certainly the rest of my esteemed colleagues, Drs. Hoffer, Balaban, Canton. Thanks very much to SOFWERX for having us down. We'll be back here again in January to spend some time with you. By training, I'm a neuropathologist. I've been doing neuroscience for about 38 years. Very often my colleagues like to call me, and jokingly we addressed this morning, a disruptive neuroscientist because I work in the area primarily of the way neuroscience can be utilized for a variety of different purposes, not all of them medical. And certainly on the medical side you can do two things. You can help or you can harm. You can withdraw certain types of care and that can be harmful, or the very same things that work on a biological and physiological system through a variety of different anatomical sites can be inductive of things that are at least burdensome, if not threatening and harmful. And that's probably what we've got here. So as you heard from Dr. Hoffer, he got a call early in 2017 that said, this is Department of State, we've got a problem. In the middle of 2017, I got a call from the Department of State that said, Dr. Giordano, we've got a question. And the question is, what do you think we're doing here? What do you think we've got here? We've got this set of findings, and apparently this is going to be some type of problematic issue. My work is fairly well known for the term neuroweaponology. Back in 2006 and 2007, we developed a paradigm by which neuroscience could be weaponized, and we assessed that on the world stage. In 2008, the National Academy's National Research Council came back and said, you know, brain science really is not ready for prime time. That was a misnomer. Our work in 2009-10 and the work of the Nuffield Council in 2013 demonstrated that not only was brain science viable and of value to be weaponized, but in many cases it was already being weaponized based upon older technology that was now taking updates and being put increasingly into a variety of circumstances that would yield individuals to be in harm's way. And we're beginning to see a little bit more of this, and perhaps this is what we're seeing here. I want to start out with that premise because I'm not going to point any fingers, I'm not going to make any accusations. However, what I want you to do is I want you to work with two things, the explicit findings and the implications that those findings give rise to. Particularly in light of the fact that by 2014, the National Academies and National Research Council reconvened and demonstrated that not only were the brain sciences viable, but they were in fact of high value and were in use globally as neuroweapons. Characteristically, when we take a look at neuroweapons, what we think of is drugs, bugs, toxins, and devices. Not all of these things will work directly in the brain. Very often they will work on the peripheral nervous system or on the neurosensory organs to then have a feedback effect that are going to disrupt the process of cognition, emotion, and behavior. What I want you to remember is that these are not weapons of mass destruction. These are weapons of mass disruption, where the disruption can be on the level of the individual and then creating a ripple effect not only on that individual and their cohorts, but on larger scales, socioeconomic scales, geopolitical scales, military scales. Keeping that in mind, it's very, very important to determine a pattern of use, with the implication being that something's going on here. And this was probably, very probably, not an incidental event. Now, could it have been? Yes, absolutely. What is the likelihood of that? Think about it. So if we're talking about things that go bump in your brain, there's a lot of different ways to get into your brain. The primary findings, as you heard from Dr. Hoffer, were primarily otological findings and vestibular findings, things that happen in the ear. And there are two terms I think that become important for you to understand. The first is the idea of otopathology, which is there's something wrong there, and the second is that this may be induced to some toxic event. The initial thought was perhaps these individuals were exposed to some compound, either an environmental compound or an intentional compound, that then caused some type of pharmacological or chemical damage to the organs of the inner ear, whether that organ was the hearing organ, the cochlea, or the organs of balance and orientation, which are the semicircular canals, the saccule and the ampule. There are a number of different drugs that could do this. So we know that there are certain things that we'll call damage to the ear, structural damage to the ear, a blow, a pressure wave. There are certain drugs that can create a toxic effect in the ear, all components of the ear. And what these will then do is they'll affect a variety of the components, inclusive of the nerve that emanates from the ear and goes into the spiral ganglion and then up into the brain. So the idea of an ear-brain connection is not foreign to this type of otopathology and ototoxicity. What are the various signs and symptoms? Hearing loss and tinnitus, vertigo, disequilibrium and nausea, visual features such as nystagmus and oscillopsia, which you heard earlier, and then certainly a whole different types of headache and or disruption of cranial functions. In other words, not only headache, but facial pain, unusual sensations, and then a loss of attentiveness and cognitive functions that can be accompanying this. Next slide, please. What type of things can do this? What type of agents could do this? Well, certainly if we take a look at just defining these into two major categoricals, we have drugs and devices. The drugs that could do this I have listed for you. The likelihood of this being a drug-induced event is very, very low. The reason for that is that the drugs would have to be given repeatedly. Characteristically, it'd have to be given either spike doses that would have another host of effects, we call a constellation of effects. This would be notable, and you wouldn't tend to see uniform effects based upon the way the drugs were given. In other words, drugs being given in different doses at different times might manifest distinct effects in different people, and would also not have this particular pattern of presentation. So we can take the drugs and say of those that we would see, would probably most notably those that are anti-tumor drugs like cisplatin and carboplatin, and probably the organic solvents. Once again, these drugs are highly toxic. There'd be no way these individuals would present with this symptom alone and not present with another cascade or constellation of symptoms that would be indicative of exposure to these agents, which then brings us down to the idea of devices. What type of things could it be? Well, it could be subsonic stimulation. It could be ultrasonic or hypersonic stimulation. It could be a combination of both, or it could be some type of microwave or electromagnetic pulse. The idea is that it could be all of these things. These are not mutually exclusive, and very often devices can in fact be manufactured that will combine one or more of these different types of phenomenon to induce a percussive effect. This is not foreign as well. We understand that during the 1970s and 1980s, a number of countries were examining the idea of electromagnetic pulse devices, sonic devices. Some of these have gone into sort of mass market production. Some of these are commercially available, even today, as Dr. Balaban will illustrate to you, and these are purchasable direct off the shelf. Moreover, we know that there have been a lot of dedicated efforts by nation states, and including from non-state actors, that have tried to work in this area primarily to create weapons of mass disruption. And we see these being used, for example, with varying success on crowds, small aggregates of people, and against individuals. But the problem is that very often, the older technology required fairly large-scale devices to implement this. However, with the sophistication of the tools that we have, we're now able to see this being shrunk down, like so many other things. I'm looking at an audience of a group of people, a variety of ages. Do you remember those first cell phones? They were about the size of a Volkswagen. We felt really good. Yeah, I'm on the cell phone. You had to hold it like this. Now take a look at the size of a cell phone. So what we see is compartmentalization and shrinkage of technology that increases its viability and utility of application. Next slide, please. This is where we're talking about. Ladies and gentlemen, welcome to your inner ear. So if we're looking at the ear, take a look at the slide on the upper left, what we see is that the ear basically has an external meatus, this thing out here, and then there's a canal. There is a membrane, which is the tympanic membrane, the eardrum, to which are connected a series of bones, which is called the ossicles. These things will move with a particular stiffness, which will then intrude onto the hearing organ, which is called a cochlea. So there are really two components of what the ear does. First is that the ear hears, naturally. However, we also have to understand that the secondary component of what the ear does is the organs of balance and orientation. These are referred to as the vestibular apparatus, and they include the semicircular canals, or the three looping canals, and the saccule and ampule, as you see here. Now, these are highly vulnerable organs to a number of different things. They're vulnerable to heat, they're vulnerable to pressure, they're vulnerable to sound. They're also exceedingly vulnerable to any other form of disruption that then cause a head trauma. So it's not unusual when individuals have a jaw fracture, a mandibular fracture, maxillary fracture, that very often you'll see secondary symptoms occurring as a consequence of inflammation. I bring that to you simply to tell you that these are exceedingly small structures that are exceedingly vulnerable to a variety of different injuries and insults. Moreover, take a look at the structure of the inner ear. The inner ear provides a mechanism by which a variety of different pulse stimuli can be amplified. Now, if we're looking at where damage can occur, particularly with regard to hearing loss, we're mostly looking at this larger organ here called the cochlea. It's a semi-stiff organ, there's fluid in the middle, and we know that various types of auditory stimuli can disrupt the cochlea and its function, shear the hair cells, induce damage. You would see hearing loss with that. Next slide, please. What types of pathologies would you see? You'd see inflammation, both locally and then more distally. You'd see hair cell damage and hair cell death. These are the organs, for example, in the cochlea that are sensitive to disruptions of the membrane that then transmit and transduce the necessary stimuli for hearing. You would see membrane scarring in any of the membranes that were affected, and you begin to see neurological damage. And realistically, we know that we begin to see neurological damage as a consequence of two things. Number one, that the nerve itself is directly damaged because of some insult to the nerve. Or number two, we then begin to see is if you're damaging the sensory organs of the inner ear, you're seeing changes due to what's called excitotoxicity of the nerve. In other words, you're overstimulating that area of the inner ear. You're hyperstimulating the nerve. As the nerve becomes hyperstimulated, you then see a disruption of neurological calcium. And with a disruption of calcium, you then get something called excitotoxicity. Once that nerve becomes excitotoxic, characteristically, you see changes occurring upstream. This is just basic neuropathology. Next, please. What type of things can do this? Well, again, a host of drugs could do these types of things, but we have to rule these out because we're not seeing drug-like effects, number one. Number two, we didn't see a constellation of signs and symptoms from these individuals that would be suggestive of some type of toxicology. And number three, the long-term effects really do not match what you would tend to see with either cisplatin or organic toxins. So as a consequence of that, we can rule this out. Some of the early hypotheses were, well, perhaps these individuals were exposed to one or more of these compounds, either directly or indirectly. Is it possible? Yes, it is possible. Might this have been a beta test where there was some priming or synergistic effect where individuals were exposed to low doses of these drugs? Yes, but these drugs were non-recoverable as well. Moreover, there didn't seem to be any other physiological signs that would suggest that these individuals received a high enough dose of these drugs to do the job. So we can rule these out. Next, please. What about sonic devices and/or electromagnetic pulse and microwave devices? Well, there's a number of different things that could be done here. Realistically, what you see is either pulsatile or tonic delivery of either a sound pulse, particularly a hypersonic pulse, that would begin in the subsonic, then translate through the sonic and into the hypersonic range. And/or you can engage some type of electromagnetic pulse, microwave pulsing, that could then affect the symptom in a very similar way, these signs and symptoms in very similar ways. You would get overstimulation of hair cells, clearly with any type of sonic delivery. You would get hair cell fatigue, breakage, and death. You would get scarring and denervation. But you would also see that if in fact it was a hypersonic pulse and/or an electromagnetic pulse, you would then begin to cause cavitation in anything that has a fluid medium in it, which would include any one of the vulnerable organs of the inner ear, the cochlea included, but most notably, those that would concentrate this type of an energy pulse most directly. In other words, an acoustic or an electromagnetic lens. Are there structures of the inner ear that could do this? Next slide, please. The auditory features you would see, if it were just limited to the auditory system, would be these. However, this was not noted, as you saw in the earlier data. We're ruling out the idea that this was just an auditory assault. Next slide, please. So if you're going to engage the diagnosis for this, and you're thinking, well, could there have been something that was focused energy that would then produce the signs and symptoms that we're seeing in these individuals with the statistical significance as was demonstrated here, what might be the viability to do such a thing? Well, you heard that. Audiological testing suggested that indeed these individuals were exposed to something, but there was no long-term audiological or hearing changes. Pharmacological or toxicological recovery early on did not demonstrate that there was in fact any toxic substances or pharmacological poisoning. Cochlear imaging is difficult to do. Biopsy and forensic anatomy can certainly be done after the fact, but your most reliable tests are those that are used in neurosensory defect. Those tests that, as you saw earlier, will determine the function of those nervous systems that are involved in vestibular apparatus, balance, orientation, and position. And in fact, that's exactly what we saw. However, there also seemed to be some mild cognitive changes that were initially somewhat high and then tapered off, and then some that were a little more progressive and that were more persistent. Is it possible, as you heard earlier, that the primary effect was localized to the inner ear and you're seeing secondary effects, what we call sequelae, where the individual's levels of cognition and emotional challenge were then disrupted by the fact that they were highly vertiginous? Yes, absolutely. I mean, look, in a previous life, I flew airplanes for a living. And I got to tell you, I mean, one of the things that happens if you put individuals in a spin or an unusual attitude, it's exceedingly disorienting. Pilots and aircrew are trained to be able to function cognitively and with emotional stability in unusual environments that disrupt their positional sense. You recognize that. One of the most curious phenomena is when an individual is exposed to either spinning or tumbling, very often what you'll find is cognitive deficits that will persist for several minutes to hours after that exposure. The longer the exposure, the longer the cognitive deficits occur. What type of cognitive deficits? Most notably with regard to information transfer, information assimilation and synthesis, and the ability to then process information in a proactive way. And if you think about it, it almost makes sense. As you heard earlier from Dr. Hoffer, it obtains. The issue here is simple. If I have to concentrate very, very strongly on orienting my environment to what is up and what is moving around, it becomes exceedingly difficult to do anything else. I can tell you that one of the things we use very often is something called a Brawny Chair. We'll put an individual in a spinning chair and then we'll ask them to do various tasks, both during the spin and after the spin. And they become so disoriented as a consequence of a loss of their vestibular senses and their positional upright and or positional surround that their cognitive capabilities seem to be grossly, grossly impacted, almost to the point that you're now seeing this is a full cognitive defect. Now clearly, when everything returns back to normal for these individuals, the cognitive defect then tapers, it diffuses or damps over time. But you do see similar phenomena with regard to cognitive blunting and cognitive defects in individuals who have profound Meniere's disease, which is an inflammation of the inner ear that then causes vestibular and semicircular disruption. Not only are these individuals positionally disrupted with vertiginous defect and dizziness, but they're also cognitively disrupted because the ability to process information, inclusive of things like upright orientation, interactions with others, then induces, as the neuroscientist Antonio Damasio says, a feeling of what happens. It is anxiogenic. It produces anxiety. If you've ever been dizzy, if you've ever had vertigo, you know that this is a very unsettling experience. And the phenomenon of that itself can be cognitively blocking. So could this be focused to the inner ear as a primary pathology that then causes secondary reactive or manifest changes in individuals' ability to process and engage cognitive information, transfer, and capability? Yes, certainly it could. But could it be more? Could it be that in fact you are also seeing an indirect or direct effect on the brain itself? Next, please. This is the idea of targeting the brain by accessing the periphery. Is it possible that what we're seeing here is not only a form of traumatic neurological injury to the ear, but a communicating neurological injury that was then able to evoke indirect or direct effects on the brain? How might that happen? Well, again, there are a number of different things that can do this. We've talked about a variety of different pharmacological agents that can co-present with some initial ototoxic or otopathologic effects, but realistically are working more in the central nervous system. But once again, we can rule these out. The reason being is we're not seeing the recovery of these agents in blood, lymph, cerebrospinal fluid, nor are we seeing the constellation of effects in the brain that would be reflective and indicative of this type of pharmacotoxicology. However, if we then focus more on the devices, there are a number of different things that could work on the brain directly and or affect the brain indirectly by working through one or more of the sensory portals. These include sonic generators, electromagnetic pulse generators, and although not necessarily pertinent to this discussion, something I do want to bring to your attention is nanoparticulate matter. And this is becoming increasingly a problem because, as Jen Snow and I are working on, this is now aerosolizable. The idea of aerosolizable nanobots has become a reality. So the idea of being able to utilize nanoparticulate matter as a neuroweapon now has become, in fact, real. What are the possible mechanisms of effect whereby you could get an indirect or direct action into what's called the supratentorial space, the space above the tentorial membrane, essentially the brain? Well, I think one thing that becomes exceedingly important to understand is that the brain is bathed in fluid. This is called cerebrospinal fluid. The brain is protected by a set of membranes called the meninges, and the meninges are basically threefold. The outermost and the most durable is called the dura mater. There's an in-between membrane that looks very much like the articulations of a spider web, and in fact it's called the arachnoidal membrane, and it is filled with fluid called subarachnoidal fluid. And then this interfaces directly with the surface of the brain, which is called the pia mater, the dear mother, literally. It's that layer right on top of the brain is very, very thin. The area of the subarachnoidal space is also a very richly vascular area. So what you now have is blood vessels that are interfacing with the fluid space existing in this kind of padded zone that looks like a spider web. So that particular structure itself might lend itself to some type of pressure damage and or cavitation damage if we're looking at the meninges. But it's pretty hard to get those kind of waves at that level of effect through the skull. But what happens if you didn't have to go through the skull? What if you could go in the side door? What if you could create a pressure wave that was amplified through peripheral structures that could then be communicated directly up into the brain? Essentially what you're doing is now you don't have to storm the castle to go through the walls. You can literally sneak through the side doors and then go up to the parapets. Let's go back to the inner ear. This is the inner ear. This is the brain. One more time. This is the inner ear. This is the brain. They live right next door to each other. They communicate. They communicate primarily through this region here. And this region here is called the ductus reunions, and this area here where there's an actual communication that goes from the inner ear space that contains fluid called perilymph into the brain is called the cochlear aqueduct. It is an aqueduct, but what I want you to take a look at is the size differential between this fairly large vestibular space, what we basically call here as the foraminal area, the opening area, sometimes referred to as the foyer, and the brain space. See the tube? This tube essentially works as a venturi. It communicates fluid between these two spaces. One of the things we worry about, for example, for an inner ear infection is the communication of that infection into the brain space that then would produce a meningitis. But if we create a pressure wave here, we can disrupt the internal structures in two ways. Number one, primarily by amplifying it through the Venturi effects, creating cavitation in this structure here called the ductus reunions, which then affects the saccule ampullus here, in the utriculus, and or by then creating an effect that would then communicate upward into the brain space by creating a cavitational wave that goes up through the cochlear aqueduct directly into the cerebrospinal fluid. Now recall, the cerebrospinal fluid bathes the brain. So what you would tend to see is injuries that occur in and around the space beginning here that could then cause a more disruptive effect as you actually disrupt the flow of this fluid. This fluid moves. Any cavitation in this fluid is going to be disruptive, and it can create something which is known as a communicating hydrocephalus. So now what's happening is you're actually getting a change in the level of the fluid because of bubble expansion, bubble collapse. This continues to communicate. It doesn't disrupt the flow of that fluid, but it can produce neurological sequelae, both short-term and long-term. The other thing that can then do is that can produce a lot of changes in the way the brain resorbs its blood flow, because this particular mechanism also affects the way blood is exchanged between the brain space and the vascular space. But the vascular space is also a portal by which peripheral disruption can then lead to central disruption. Next slide, please. So clearly, if we're looking at the paralymphatics, we can see that, once again, disruption of the paralymphatics, as we said earlier, can communicate into the brain space. It can also communicate up here into the subarachnoidal space, because we know that the paralymph will communicate with the CSF via that particular aqueduct. But once again, we have blood vessels that are embedded within this subarachnoidal membrane that then interface directly with the substance of the brain. If we disrupt that fluid around the brain, could we then create a disruptive pressure wave by cavitation into these blood vessels that would then be communicated into the brain space by both the paralymphatic CSF communication and the blood space? Yes, we can. These things are essentially talking together. Next slide. So if we look at these communications, what we can see is that any type of communication here into the subarachnoid space is capable of inducing a variable pressure wave, a cavitation wave, inclusive of cavitation damage, at a variety of different brain locales. We know that one of the things that this can then do is that can actually disrupt the integrity of the tissue, because you're now increasing two things. Number one, localized pressure, which then actually creates a traumatic event, which can then lead to axonal shearing, and vascular effects, which can then disrupt the blood flow to the brain. Disrupted blood flow to the brain can then lead to microhemorrhagic infarcts, small level blood flow disruption, small areas of necrosis in the brain, and this would then be more long-term. So clearly, one way we could affect the brain through the inner ear is through the fluid medium that occurs via the inner ear directly to the subarachnoid space, affecting the fluid medium that surrounds the brain and thereby causing a disruption to the brain structure directly. But we can also affect the blood, and there's a number of different ways we can affect the blood. Certainly, we can engage the inner ear, and most of the pathology we're seeing here with this embassy encephalopathy would suggest that the inner ear provides for us an acoustic or some other form of energetic lens. This is going to concentrate this type of information, create a disruption primarily in the vestibular area in and around the foyer that would then affect the saccule and the ampullus. This would then disrupt the function of the inner ear. This could produce a cognitive constellation, but at the same time could have a secondary disruptive effect where it's now creating a cavitation wave that spreads throughout the paralymphatic fluid, communicates via Venturi effect up into the cerebrospinal fluid space, disrupts the flow of the cerebrospinal fluid in the subarachnoidal space, and thereby can also disrupt the vasculature. But could you disrupt the vasculature directly? Could you incur cavitation changes in some area of the vasculature that's going to affect both the inner ear and the brain? Oh, yes, you can. This is the area in and around the inner ear. And what we can see is that there is a direct concentration of blood vessels. Once again, take a look at the upper left-hand portion of the slide. This shows the arterial supply to the inner ear, the utricle and the saccule. This is supplied by the anterior vestibular artery, which forms a direct connection to the basilar artery, which then communicates to the cerebral arteries, most notably the middle cerebral artery. The middle cerebral artery branches up into the brain and has what's called here this lacunar effect. In other words, there are these deep penetrating arteries that go into the brain space. These are exceedingly small vessels, and the concentration of pressure within these vessels is exceedingly important to maintain a variety of neurological responses and cerebrovascular responses. These things will change as a consequence of local pressure, and they'll alter the blood flow to maintain stable pressures across the brain space. The brain is highly vulnerable to these types of things. But if you disrupt the flow of arterial blood, you're going to get two things. Number one, you get a compensatory arterial response, and you're going to see changes in perfusion that will occur on the vascular side. If this occurs as a consequence of bubbles, which you're essentially producing here is microemboli. Can the microemboli lodge here in these lacunar vessels to create lacunar infarcts, microstrokes? Yes, indeed they can. Can you get disruption of the brain space directly by disrupting the arachnoidal membrane, by disrupting the fluid that exists in the arachnoidal membrane, by disrupting the fluid of the perilymph in the ear? Yes, you can. Can you do both at the same time? You betcha. What would the effect be? Well, clearly, if you're disrupting the inner ear directly by affecting the foyer, by affecting the utricle and the saccule, by virtue of a pressure wave, then creates some type of cavitation within those structures that are fluid-filled structures, you're going to disrupt otolithic effects and you're going to get a change in the balance organs and balance function. Could that lead to problems with regard to cognitive processing? Absolutely. But based upon the structure of the inner ear, could you also then begin to cause neurological changes and neurological damage? Yes, that's a possibility as well. You could certainly begin to cause degenerative changes at the innervation of the inner ear that could communicate along the cranial nerves to then have a neurodegenerative change. Is this easy to determine? Not necessarily, but certainly it could be done by virtue of certain types of imaging and certain types of nerve conduction velocity testing. But what if you didn't have to affect the nerve itself and you can get directly into the brain? The same pressure wave that would affect the utriculus and the saccule could indeed create a pressure wave with inside that foyer that would affect two components that would directly and indirectly assess the brain. The first direct effect being the communication through the perilymph of cavitation disruptions that then enter through the cochlear aqueduct to perfuse the subarachnoidal space and cause a disruption in cerebrospinal fluid. And the second, which would be a disruption of the vasculature here in the arterial blood supply that would then communicate back to the basilar artery and communicate up with cavitation and the blood flow to the brain. So what you see here is converging pathologic effects, disruptive pathologic effects. Next slide, please. How would we look to assess these types of things? You've already heard this. I'm not going to repeat the information. Dr. Hoffer's group did a wonderful job in neurocognitive testing, neuroimaging. Clearly, if you wanted to look a little more deeply, you'd have to take a look at some of the forensic anatomy upon biopsy, necropsy. But you could also model some of this work in vivo, in vitro, and with computer simulations, which becomes probably the most accurate way to take some simulacrum in a phantom or in some other type of situation that would then model what these effects would be on the mammalian ear and on the mammalian brain. Of course, for that, our next speaker, Dr. Balaban, will discuss some of the work that he's done to empirically demonstrate what these findings not only are, but what they could be based upon not only the type of image we see here, but the type of image that we would then see if we were to increase the frequency or change some of the electromagnetic pulsing. Next slide, please. So, based upon that, what's the take-home messages I have for you? Like anything else, let's go through a process of elimination. We have to go about this somewhat deductively. In other words, we have a set of individuals who've suffered these particular constellation of signs and symptoms, and we recognize that from that, these are the things we're seeing. What types of changes could we be seeing in the peripheral and central organs, neurosensory organs, and in fact the brain that might be indicative of this and what could do it? Is it possible that drugs alone could have done that? Well, early on in our discussion, we ruled that out. Is it possible that ultrasonics could do this? Yes, this is very likely and highly probable. Is it possible that electromagnetic pulsing, microwave pulsing, in some way could do that? Very possible, highly probable. Is it also possible there may be some combinatory approach, a beta test, if you will, to see if we give drug first at a low dose or ultrasonics at a low dose coupled with some type of electromagnetic pulse microwave dosing, in some combinatory form, could these be worked? Quite possible with very positive explanatory value. In other words, if someone put a gun in my ear and said, which one do you think is going to produce this constellation of effects that we saw in those individuals who were most affected not only in Cuba, but more recently in China, I would tend to think that what you're probably finding is this last one. Whether or not drugs or some other form of pharmacotoxicologic agent we use, I think remains dubious, but certainly there are devices that are widely available that we also know have been dedicated activities in the neuroweapon space by a variety of nation states that would be capable of doing just this type of thing. The inner ear provides a locus, a forum, for this to then be conducted in such a way to manifest these effects, but it's not the inner ear alone. It could occur through the sinuses, both the ethmoid and the sphenoid sinuses. It could occur through the hard palate of the mouth. Any one of the vulnerable amplifying spaces of the head could do it, and certainly what becomes important is how such a weapon could then be focused and utilized in those ways to be able to create this effect. Might it be, once again, that this was something that was serendipitous, stochastic, that this was some type of vermin protecting agent or device that was simply in those rooms to which these individuals were then suspect? Perhaps. Is that likely? Not very. The reason for that would be that many others would have these signs and symptoms, number one. Number two, there would be some engineering artifact that would then be attributable. Here's the device, this is what it was being used for, and there would be an attribution or custodial record for that. Absent that, once again, by virtue of implication, this is intentional, this is directed, and this seems to be a beta test of some type of a viable neuroweapon that utilizes one or more of these modalities for its effect. Next slide, please. That's all I have for you. Clearly, what I'd like to leave you with is speculation. Speculation based upon the facts of the case, speculation based upon what we know about the weaponology, or at least the deviceology, speculation about what we know about what the pathology is and could be, and how this would work. So what I'm asking you to do is something quite simple. Take the facts of the case based upon the findings that were presented to you by Dr. Hofer. I want you to take the level of possibility and probability in terms of what the viable structures are that could communicate such effects in real-life terms, and then pair that, if you will, to our next set of speakers who will not only talk about what the empirical findings are that could reproduce this in a modeled scenario, but how this could also be leveraged geopolitically with regard to the viability of an increasing capability, confidence, and consideration in neuroweaponology. Thank you.